Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. This program was made possible through support from both our donors and our industry partners. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robin. I would like to welcome our audience to today's event. We are joined by my friend, Dr. Samir Parikh, Associate Professor in the Department of Hematology at Mayo Clinic in Rochester, Minnesota, and a member of CLL Society's Medical Advisory Board. Dr. Parikh will be sharing research from ASH in regards to non-covalent BTK inhibitors and BTK degraders. And I'm going to be presenting some of the latest information on zanubrutinib, which was just FDA approved by for CLL, also acalabrutinib, and some clinical trials regarding Richter's transformation and just some other interesting information. So let's get started. ASH 2022 had a number of important updates for the CLL and SLL community, and I'm going to give a top line of some of these that I think are important. I'm going to start with one of the screaming unmet needs in CLL, and that's Richter's syndrome or Richter's transformation. And I'm going to talk about a new kind of drug in the CLL world, though these have been used for a long time in lymphoma, and that's a bispecific antibody, specifically subcutaneous epcoritamab. Now, two things that are interesting about this drug. The first is the way that it's given. It's not given through an intravenous infusion, but it's given through an under-the-skin injection, which has tremendous convenience for the patients. The second is that it's bispecific. So what that means is that not only does it bind to the CLL cell, and in this case, it binds to the surface marker CD20, which is the same that rituximab and obinutuzumab bind to, but it also binds to CD3, which is found on the T cells. And by binding on both of those, it pulls those two together. The study was small. There were only 10 patients in the study, but the early data was certainly encouraging for this very difficult to treat disease. Cytokine release syndrome was seen in 9 out of the 10 patients, but all of them were mild. Patients had anemia, diarrhea, and other problems associated with it. And 2 patients passed from their disease progression. But overall, the response rate was 60%, and the complete response rate was 50%. Most response happened early on. So this is exciting and very early data about a subcutaneous bispecific antibody for Richter's syndrome, this great unmet need. Next, I'm going to move on to a study that people know a lot about called the Captivate study. And we're going to look at the outcomes after reaching undetectable, measurable, or minimal residual disease with first-line ibrutinib plus venetoclax. And now we have data up to 5 years out. And these were younger patients under 70, and they looked at the patients who'd reached undetectable MRD, measurable residual disease, in both peripheral blood and the bone marrow. And they were randomly assigned to either get placebo or to stay on ibrutinib. So there was 164 patients in the combined ibrutinib and venetoclax treatment. 86 were undetectable UMRD, were randomized to either placebo or single agent ibrutinib. The follow-up time was long, it was 56 months. And the undetectable measurable residual disease stayed stable for 2 or 3 years after randomization. Progression-free survival was 88%, and overall survival was 100% with the placebo, and 95 and 98% with continued ibrutinib. So if you're listening to that data, you're saying there wasn't really much difference between placebo and continuing on ibrutinib if you reached undetectable measurable residual disease. They also did a subgroup analysis and found that for those at high risk, it was the numbers were similar. So what are our conclusions? Our conclusions are that continuing ibrutinib after ibrutinib and venetoclax in the patients who reached undetectable MRD added no significant benefit. Ibrutinib and venetoclax is an all-oral, once-daily chemo-free regime that continues to provide deep and durable responses, and it can be stopped after a fixed duration. Very exciting and post-hoc analysis of the Captivate trial. This is one of the biggest trials presented at ASH. And this was the late-breaking abstract that was presented. Actually, this was the very last paper that was presented at the American Society of Hematology meeting. And this was the Alpine study, zanubrutinib demonstrating superior progression-free survival compared to ibrutinib in relapsed and refractory CLL, SLL. So we know that CLL and SLL are diseases that are characterized by patients doing well for a while, then needing treatment, then relapsing, responding to another treatment, and needing another treatment. So the more durable the response is, the better those patients are going to do. This was a very large study, 652 patients from 15 different countries, and the populations were well balanced. The median progression-free survival for patients who were randomized to ibrutinib was almost 3 years, 35 months, but it is not reached for zanubrutinib. Treatment discontinuation was lower on zanubrutinib, 26% versus 41% on ibrutinib, and that was mostly due to adverse events or progressive disease. Rates of atrial fibrillation were lower on zanubrutinib compared to ibrutinib. There was no deaths due to cardiac disorders among the zanubrutinib arm, but there were 6 or 1.9% with ibrutinib. 48 or 14.7% of the patients treated with zanubrutinib and 60 or 18.5% of the patients treated with ibrutinib died. So 48 or 14.7% with Zanu died during the study compared to 60 or 18.5% with ibrutinib. So this is the first head-to-head study that suggests ibrutinib, comparing ibrutinib to zanubrutinib, and it shows that zanubrutinib is more efficacious and better tolerated than ibrutinib. And here's a graph that shows that. This is a Kaplan-Meier curve, and the closer to the top, the higher the survival numbers are. And if we look at those numbers, both in the general population, we can see that at 24 months, 79.5% of the patients on zanubrutinib have not progressed compared to 67.3% on ibrutinib. And if we look just at the 17p or TP53 patients, we see similar numbers, 72% versus 55%. This is the first study comparing 2 covalent BTK inhibitors that show one has a better progression-free survival than another. This is certainly an important paper at ASH that we can discuss more during the Q&A. Another paper that I wanted to spend a little bit of time on is there was a big push at ASH towards doublets and triplets, and we should be looking to see, does it make sense to be adding other drugs when we already have one effective drug? So one combination that's gaining in popularity is the combination of obinutuzumab, which is a monoclonal antibody to acalabrutinib, and what effect does it have on progression-free survival, or PFS, and overall survival? And this was as a frontline therapy in treatment-naive patient. So knowing when to add O to A of obinutuzumab to acalabrutinib is going to be critical, because we want to make sure we're getting benefit for increased toxicity. So this is a study that compared 197 patients on A plus O versus 179 on A alone. And what we found is progression-free survival in the patients who had the obinutuzumab added was significantly better in the unmutated IGHV patients, the patients without deletion 17p, the patients with mutated IGVH, and the patients with no complex karyotype abnormalities. Progression-free survival was significantly improved. We also found that overall survival was improved in that dual, the acalabrutinib plus obinutuzumab versus acalabrutinib alone for patients in a similar groups on unmutated IGHV without deletion 17p or TP53 and with no complex karyotype. What is interesting is there was no significant improvement in patients with deletion 17p, TP53, or in patients with complex karyotype. So what are our conclusions? Patients with unmutated IGHV or without deletion 17p or TP53 mutations or complex karyotype abnormalities benefit from having obinutuzumab added to acalabrutinib therapy. But it's unclear if there's any benefit for patients with deletion 17p or TP53, leaving a significant unmet need there. So it's allowing us to fine-tune our therapies. Before we close up, there were several other abstracts that I wanted to make sure that the CLL community was aware of. Some because they're pointing the way to the future, and some because they're telling us what's happening right now. So I picked 5 out, and it's a somewhat arbitrary choice, but let me share them with you. The first is a drug that's of particular interest to me, and it's a new drug that's in a dose escalation trial, so very early in its development, called MS553. And it blocks a new acronym you're going to have to learn, PKC beta. And why this is important, this is another way to block the B-cell receptor. So we all know how that's done by BTK inhibitors, and we know how it's done by PI3 kinase inhibitors. And this is another way that's downstream from BTK. So the hope is, and the early data seems to suggest that patients who develop resistance to the approved BTK inhibitors, and even patients who develop resistant to the non-covalently binding BTK inhibitors, like pirtobrutinib, would still be sensitive to the new drug MS553. It's very early. It seems to have significant GI side effects, but very interesting. I'm now going to talk about 2 of the papers that dealt with COVID infections. And there were many, many papers on COVID infections. So the first one is from the Leukemia and Lymphoma Society, and it dealt with breakthrough infections. And first, I'll give you the bad news. The bad news was that there was about a 10% incidence in patients with heme malignancies who had at least 2 to 4 vaccines who still had a breakthrough infection during the early Omicron surge, the B1.1.529 surge. The other piece of bad news is it didn't seem to matter whether you formed antibodies or not to the vaccine. The breakthrough infection rate was very similar into those who responded to the vaccines and those who didn't. The interesting piece of news, the important piece of news, is that the patients who responded to the vaccine, who developed antibodies were the ones who did not end up hospitalized. None of the patients who developed antibodies were hospitalized for their COVID. So even though they had the same risk of getting COVID, their risk of getting serious COVID, where they ended up hospitalized, was eliminated. A second very positive data came out of a study that looked at CLL during the Omicron subvariant surges. And they compared to the early surges, the BA1, the BA1.1 to the BA2 and the BA5. And without going through all the details, it was very good news. With each surge, the incidence of hospitalizations, ICU admissions, and mortality continued downward until the point where in the last surge, there was no significant mortality associated with COVID for CLL patients in the very last surge that this recorded, the BA5 surge. Why this is not clear. Is it the vaccines are working to some extent? Is it that we had Evusheld aboard at that time, which was effective during these surges? Was it that we have great antiviral drugs? Not sure, but certainly very good news. Now I'm going to move on to an area that's of particular interest to me, and I think should be of interest to any CLL patient, and that is the tumor environment. This paper was called Targeting the Inflammatory Pathways to Reverse the Immunosuppressive Tumor Microenvironment in Chronic Lymphocytic Leukemia. So we have learned over the last decade that targeting the CLL cell itself is extremely helpful, but targeting where it lives, its protective niches in the bone marrow and in the lymph nodes, may be equally important in preventing the disease from coming back. And it turns out that the CLL cells are very good at pirating the environment that they live in and turning it into support for their cancer and avoiding their cancerous growth and avoiding anti-cancer drugs. And this does through setting up an inflammatory pathway. And one of the chemicals involved, in this pathway, is something called S100A9. And it turns out that if you inhibit this, the CLL growth is slowed down, and it also suppresses some of the immunosuppression. In other words, I use two negatives there. It starts to turn off the negative effects on the immune system. It starts to reinvigorate and build the immune system. So this is very exciting research, very, very early, but looking at the microenvironment is going to be really important. And the last is a paper that tells us that we still have a way to go, and that discusses racial, ethnic, sex, and income disparities and its effect on overall survival in chronic lymphocytic leukemia. And this is Sears data. This is a large government registry. And what it tells us is something that isn't surprising, but is sad to learn. And that is that for non-Hispanic Blacks, generally their outcome with CLL is worse. Generally, they're diagnosed later on when the disease is more progressive. We've also found that patients below certain income levels have much worse outcomes with CLL. Again, not surprising. But it's sad to see that these realities still exist today, and it's an important area for our community to address and make sure that everyone gets the benefits of the best possible therapies. Lots more to talk about ASH. I look forward to your questions. But before that, Dr. Samir Parikh is going to bring you up to date on some of the really important research that he was interested in, some of which he was directly involved in, that involves BTK inhibitors and other interesting ways to control your CLL. Dr. Samir Parikh, please.
Hi, everyone. Thank you very much for joining today's seminar. My name is Parikh. I am an associate professor of medicine at Mayo Clinic in Rochester, Minnesota, and I'm delighted to be here today. Going to go over some of the data that have been presented at the American Society of Hematology meeting that concluded in December of 2022. I will also be available for questions after this presentation. So I look forward to interacting with all of you. I'm going to share some data that have been presented, and I'm going to keep it very high level. And I'm sure that you will have some questions as we are done with this. Again, like I said, I'm happy to answer those questions about these particular studies that were presented or other studies as well. And so the area of focus that I'm going to talk about in the next several minutes really pertains to a class of drugs called as BTK inhibitors. Now, these are what are called as Bruton tyrosine kinase inhibitors, and they really form an important treatment paradigm for patients with chronic lymphocytic leukemia or small lymphocytic lymphoma. And over the past decade or so, they have been used in multiple different settings and have really shown remarkable efficacy in the management of CLL. There are 3 currently available BTK inhibitors that are all FDA approved, including ibrutinib, acalabrutinib, and zanubrutinib. All of them are approved in the frontline setting, meaning if you have never received any prior CLL therapy, and in the relapsed setting, meaning you may have received some other treatment for CLL in the past and now need CLL-directed therapy. The figure below on the left shows some differences between these inhibitors. What we really like to see is that these medications actually inhibit only the BTK enzyme, which we think is very important in survival of CLL cells. But what in fact happens is that these molecules not only inhibit BTK, but a wide variety of other enzymes that can cause a lot of side effects. And so the more specific a drug is, the less likelihood that there will be additional toxicities with the use of that drug. And now we've seen some data that suggests that these so-called quote-unquote second-generation BTK inhibitors like acalabrutinib and zanubrutinib are likely better compared to ibrutinib from a toxicity perspective. And that really is reflected here, where you see that there is a small amount of off-target, meaning off BTK inhibition of enzymes with the use of acalabrutinib compared to ibrutinib, where it inhibits many more enzymes. And a similar story emerges when you compare zanubrutinib to ibrutinib. So in general, I think there is a push towards considering the use of second-generation BTK inhibitors, such as acalabrutinib and zanubrutinib, in the management of CLL. One important point that I'd like to highlight here is that both acalabrutinib, zanubrutinib, along with ibrutinib, are what are called as covalent BTK inhibitors, and that's a different class of drugs compared to what I'll discuss next. Unfortunately, what happens is because these drugs are given in a continuous fashion, it leads to resistance. So the CLL cells actually figure out a way around these medications, and resistance develops, leading to disease progression, necessitating that we use different treatments after these treatments have stopped working. And here is a listing of some of the genes that actually undergo mutation that does not allow for all of these medications to work. And some of these commonly mutated genes include BTK gene, PLC gamma 2, and these really drive the resistance patterns in patients who have been on these covalent BTK inhibitors. And so the 3 presentations that I'm going to focus on really reflect on how can we get past resistance to these covalent BTK inhibitors. And the 2 drugs that I'm going to discuss first include the non-covalent BTK inhibitors, and these medications act at the same enzyme on the BTK enzyme on the CLL cell, but in a different mechanism, such that even though patients may have received covalent BTK inhibitors in the past, these drugs that are non-covalent BTK inhibitors do work in that situation. And then a novel class of drugs called BTK degraders and a compound called NX2127 is one that was presented at the ASH meeting that I'll review the data for. So talking about pirtobrutinib, which is, like I said, a non-covalent BTK inhibitor. And you can see that this is the kinome map of pirtobrutinib, where it inhibits BTK, but has very little off-target effect, where these red dots represent inhibition of other kinases, and again, reflecting the highly selective nature of this molecule in inhibiting BTK. In this study, patients who had previously received a covalent BTK inhibitor, such as ibrutinib or acalabrutinib, and even a BCL2 inhibitor, such as venetoclax, which is another very commonly used drug in the management of CLL. These patients were all eligible to participate in this particular study, where they all got pirtobrutinib. It is an oral drug that is given on a continuous basis. And in this study, 247 patients with CLL were treated, and the overall response rate was an impressive 82%. What you see in this so-called waterfall plot is you start off at 0%, or actually I should say at baseline at 0, and then see once the drug is started, what proportion of patients experienced an improvement in the lymph node enlargement or the spleen enlargement. And as you can see that barring a small number of patients where there was no improvement seen, the vast majority of patients experienced a significant improvement in the lymph node enlargement, which is really reflected in the overall response rate of the drug at about 82%, suggesting that this drug is very efficacious. Now, we know that the drug is efficacious, but the question really is, for how long does the efficacy last for? And this study suggests that the average length of time for which pirtobrutinib works after other BTK inhibitors, the covalent BTK inhibitors, have stopped working, is about 1.5 to 2 years. Now, you might say that that's not a very long period of time, but I want to remind you that patients that were treated on this study actually had received many, many other prior lines of therapy and had relapsed and refractory disease. And despite that, this drug showed a remarkable efficacy at about 18 to 24 months for how that much long period of time it worked for. Certainly, we need to think about what next once our patients have had a response to this treatment, but this is extremely encouraging. Another important point to remember is that I talked about the BTK mutation that can happen in patients who have received a covalent BTK inhibitor. Pirtobrutinib was shown to be efficacious regardless of the presence or absence of these mutations, suggesting that the mechanism of drug resistance to prior covalent BTK inhibitors does not matter when you use pirtobrutinib. Also, it remains to be seen with longer-term follow-up, but early on, with close to 250 patients being treated, it appears that the side effect profile of this drug is very favorable. And so, for example, some of the side effects that we have come to know with the covalent BTK inhibitors, including bruising, rash, muscle aches and muscle spasms, other bleeding episodes that can happen, high blood pressure, or an abnormal heart rhythm called as atrial fibrillation, the risk of these adverse events is very low. Now, if you look at any grade, it appears to be quite high, but what we really try to focus on is grade 3 or higher. And over there, the risk appears to be quite low. Again, like I said, this is early on. The drug has been in the market, has not been, approved for CLL, but it's been in clinical trial testing, and with longer follow-up, we will know more about the long-term side effect of this particular drug. But so far, it appears to be very promising. An important thing to remember is that pirtobrutinib is now approved for relapsed mantle cell lymphoma. This is a different type of a lymphoma. And what this allows us to do as CLL doctors is that we can now prescribe this medication in an off-label indication. I don't think we should do this in patients who have not received covalent BTK inhibitors such as ibrutinib, acalabrutinib, or zanubrutinib, or patients who have not received venetoclax. But this is really in the patient population that was used in this particular study, which is the patient population that has had progression of disease on both a covalent BTK inhibitor and venetoclax. And I think until the pirtobrutinib approval for CLL comes through, we should consider using this in that very select patient population to be able to give them the benefit of what this drug is able to do from what this study tells us. Now, similar to pirtobrutinib, which is a non-covalent BTK inhibitor, there is another drug called nemtabrutinib, which is also a non-covalent inhibitor, BTK inhibitor. And here in this study, patients were treated with this oral drug. The overall response rate was 56%, and the average length of time, and we look at the 50% length of time where it works, was approximately 12 to 18 months, considering both these cohorts. And there were several cohorts of patients that were treated in this study. Again, this suggests that the drug works in patients who have had progression of disease after a covalent BTK inhibitor. And it also suggests that the drug works for about 12 to 18 months once those drugs that were typically used, such as covalent BTK inhibitors, stop working. The side effect profile appears to be slightly different compared to pirtobrutinib. An important side effect to think about in this drug is what we call as dysgeusia, or abnormal taste, that was seen in a number of patients. I'm told that this is short-lasting and it goes away once the patients have been on this drug for a long period of time. And then there are a variety of other side effects, again, to be expected, where your blood counts can become abnormal, fatigue, nausea, etc. Again, this suggests that this drug is active and it can be considered as one potential treatment option in patients who have had progression of disease on both covalent BTK inhibitors and venetoclax. Finally, I'd like to talk about this BTK protein degrader compound called NX-2127. Now, this is a novel class of drugs. Just from a mechanistic perspective, all the proteins in our cells inside the body are degraded using what is called as the proteasome. And that really is a major player inside the cell that gets rid of all the waste. And in essence, all the proteins, including the BTK protein, goes through this recycling process. However, because of the abnormal BTK protein that is present in patients with CLL, particularly in those patients where there has been progression of disease, it sticks around and is not degraded as easily. And that is really where this BTK protein degrader comes in, where it helps enzymatically modify the BTK protein, which is then degraded by the proteasome, and that allows the CLL cell not to survive and die. And so in this study, there was a large sort of cohort of patients, including those that had CLL and other types of lymphomas that were allowed to be included. And in a typical dose finding sort of study, patients started with a very small dose at 50 milligrams, and ultimately the dose was increased up to the maximum tolerated dose of about 300 milligrams. And these data were very preliminary, but what they demonstrated was that there was about a 33% overall response rate after about 6 months on study. And you can see on this graph on the right where there are many patients, similar to the waterfall plot that I showed for the pirtobrutinib study. You can see that a number of patients actually had a very good response. Now, this is very early. This is only about 15 patients that were treated on this study with CLL. And so it remains to be seen with longer follow-up and with more patients, how do those patients do and what kind of efficacy does the drug provide in this patient population. The side effect profile appears to be similar to other BTK inhibitors, such as blood count abnormalities, the abnormal heart rhythm called atrial fibrillation, etc. And so again, I think, like I mentioned, we really need more patients in this particular demographic that have had progression of disease on both a covalent BTK inhibitor and venetoclax before we can tell with confidence where this drug ends up in the big scheme of things as far as CLL treatment is concerned. And so I hope that highlighting these three abstracts or studies gives you a flavor of the newer classes of drugs that are being developed to treat CLL patients who experience progression of disease on a covalent BTK inhibitor such as ibrutinib, zanubrutinib, or acalabrutinib. I think it's important to know that if you have disease progression on a covalent BTK inhibitor, that another covalent BTK inhibitor should not be used because it would not work in that situation. But a non-covalent BTK inhibitor such as pirtobrutinib or nemtabrutinib would be expected to work. Finally, I'd like to put in a plug for clinical trial participation because currently patients who have progression of disease on both a BTK inhibitor as well as venetoclax represent an emerging area of unmet need in CLL because a number of patients unfortunately don't do very well after both of these drugs classes have stopped working. And that is really where clinical trial participation is paramount because these drugs, when they are tested in the context of a clinical trial, will hopefully lead to approval and will allow us to continue to improve the quality and the quantity of life of our patients. Obviously, there are many other treatment types that I have not covered over here that are all being investigated, including chimeric antigen receptor therapy, such as CAR T treatment, transplant, et cetera, et cetera. And I'm happy to answer any of your questions as you have during the Q&A session. I'd like to thank you for your attention. And again, thank you for the invitation to present and discuss these studies with you today. Thank you.
Dr. Parikh, thank you so much for that overview. I think I learned some new insights into this research. I also, and I'm sure others found this too, that this was a lot of material to cover, and we covered a lot of it quickly. So the good news is that this will be archived and available usually within about a week or so. We'll have links to the actual papers. A lot of these we've gone into in more depth, and we'll include those links for you. So don't worry if you didn't get every nuance of this at this time, because it's a lot to take in. I'm going to try to get to all the questions. If I don't get to all your questions, Dr. Parikh and I, we do have Ask the Expert, and please send those questions in, and we'll try to answer those for you in the following week. So we have over half an hour for questions, but I'm not sure even that's going to be enough time. So I'm going to try to put them together, and Dr. Parikh and I will try to go over them, but I'm going to start with the questions that were sent in advance. And Dr. Parikh, one of the main goals in CLL research is reconstituting the immune system. And I mentioned that one paper that targets the microenvironment. Mayo has looked pretty hard at the microenvironment. That's been one of your strengths. We seem to be getting better and better at controlling the CLL, but we still remain immunocompromised with all these therapies. We're still dying of infections. We're still getting second cancers. What's going on in research to reconstitute the immune system? Was there anything that you saw at ASH that got you excited?
Yeah, hi, Dr. Koffman. Thank you very much again for the invitation. I'm really happy to be here. It's always interesting to see the questions that come from our patients, because that's really important for us to think about the research direction, because obviously we are here to help our patients as best as we can. I think, as we talk about the tumor microenvironment, I think ibrutinib or any BTK inhibitor really is sort of the paradigm for treatment, because it really works in the microenvironment where it turns off the signaling of the BCR receptor. That really is where, without even killing any direct killing of CLL cells, you see a lot of response to ibrutinib or any other BTK inhibitor-based treatment. I think it was hoped that as these patients progress through this treatment and as there is a response to treatment, there is going to be a reconstitution of the immune system. And I think we have seen some of that. There is partial restoration of the immune system, but it's clearly not enough. It's not as much as we would have liked for it to happen. So I think increasingly there is the focus on trying to deepen the response to therapy. And I think, as I see many of the questions, can you deepen the response by giving venetoclax, for example, or giving an anti-CD20 antibody? I think the question really is, can you get rid of the CLL cells and hope that the immune system recovers completely? I think that's a challenge, because any treatment that we add on to what we are currently doing, that has the potential of further suppressing the normal immune system. And so I think we have to be careful in how we think about combination treatment strategies that are being done in CLL right now. Having said that, I think there are a lot of trials that have looked at how can we modulate the immune system, how can we shorten the length of treatment in CLL patients, and how will that improve the immune system. So certainly there is more work to be done in this space. We are not quite there yet. And I think the immune system issues continues to remain a problem for our patients, unfortunately.
Thank you for that, Samir. There's a whole raft of questions about early intervention. And this comes up every time we talk about CLL management. And in the past, though not so much at the ASH, we've seen papers about trying to intervene early. And it seems so counterintuitive. We don't wait until somebody's hypertension causes a stroke and then say, okay, let's treat your blood pressure. So why are we waiting in CLL? We don't wait in breast cancer. We don't wait in other diseases. Can you talk a little about that and the research? And there are some ongoing trials that are looking at high-risk patients. And what do we know about that early intervention? Are we starting to shift that paradigm as we have better and better drugs?
Yeah, thank you, Brian, for that question. And I'd like to thank the audience members who posted this question. So I think this is one of the most common questions that I get in the clinic is, you tell me I have CLL, a type of a leukemia, and you're telling me go home, we're not going to do anything, right? And I think that is so counterintuitive to everything that we tell our patients, that go get a colonoscopy, you find a polyp, you can take it out. Fortunately or unfortunately, we can't really do that with CLL because it is a blood cancer. It is a type of a leukemia, and leukemia is blood cancer, which by definition goes everywhere. So there isn't a surgical option or a radiation therapy treatment option to get rid of this cancer because it's basically everywhere in the blood, which is everywhere in our body. So the only treatment option that would work would be systemic therapy, which means you either get it orally or you give intravenous forms of treatment. Now, going back decades, there have been multiple clinical trials that have been done where patients with early stage disease who do not have a lot of disease burden, meaning they have cancer cells in the blood that were detected incidentally or have small lymph nodes, but otherwise don't have any physical limitation in what they're able to do, these patients were randomly allocated to either treatment versus no treatment. And over the years, the treatment has changed. So there have been treatments that have constituted with that were with chlorambucil, with regular chemotherapy like fludarabine, combination chemotherapy with FCR, which is fludarabine, cyclophosphamide, and rituximab. And more recently, even the CLL-12 study where patients got ibrutinib versus placebo. None of these studies have actually shown that patients live longer with either approach, meaning that if you were given placebo or you were not given any treatment and you were observed for a length of period of time, and then you developed symptoms or other signs of blood numbers getting abnormal, and at that point you were treated, it did not matter because you can easily play catch up even at that point. And so the paradigm really has been, if you have early sort of cancer that was detected and it's not really causing any trouble, and if we can't make you live any longer and we can't make you live any better, then what's the point of intervention? And that really is the reason why we don't treat everyone up front if they don't have some of the indications for treatment. Having said that, there are now two things that have changed in the last sort of decade or so. One, we have newer and better drugs, like you mentioned, right? And so certainly they are not as toxic as some of our chemotherapy treatments that we've used in the past. And another important thing is now we have the tools to be able to better predict which patient is likely to have faster progression of disease, because you frequently hear many patients say, well, I know of a patient with CLL who lived for 25 years, never needed treatment. And then on the flip side, you hear of patients who needed treatment right away or within a month of being seen in the clinic. And so now we have the tools to be able to predict where a patient's disease is likely to be. And so, like you mentioned, Brian, there are now clinical trials. And I'd like to draw your attention to a trial that our colleague, Dr. Debbie Stevens, is leading. It's a national trial, very important study that the Southwestern Oncology Group is leading. And it's an intergroup study that treats patients with high risk disease of high risk of disease progression, I should say, and randomizes these patients into either early intervention with venetoclax and obinutuzumab or delayed intervention. And I think this trial is important because it will hopefully allow us to understand whether early intervention really matters. So this is a long-winded answer to your question, Brian, but I think I saw a number of questions about this. So hopefully this answers all the questions that were there in the chat box.
Well, another big area of questioning, and it has to do with the Alpine trial that I suggested, that I reviewed, but also covers a lot of other things that are related, where now we have 3 great BTK inhibitors for CLL and another one for mantle cell that can be used. Let's talk about that for a minute here. I'm wondering how you approach this. If a patient is doing well on one of these drugs, do you say, well, there's just this recent study, I should change them? How do you make decisions now as a clinician? You're sitting with a patient about these excellent drugs that we have for CLL in terms of what to be using frontline, what to be doing if somebody's doing well. And then I've got some follow-up questions that people asked about that.
Yeah, so I think in general, I don't switch therapies. If someone's tolerating a medication well and it's working well, then I do not typically will change treatments, because if someone's been on ibrutinib for 3, 4, 5 years and they don't have any side effects and it seems to be working well, I'll leave it alone. On the other hand, there are always patients that have these sort of low-grade nuisance toxicities, and they wouldn't really know whether it's really the drug that's causing it or it's just the fact that everyone's getting older and my joint aches are just a part of getting old, and sometimes it's very hard to tell the difference. And so in those patients, I might say, well, why don't we try taking a break from ibrutinib or acalabrutinib or zanubrutinib and see how you feel? And if they feel incrementally better, then I would much rather talk about either switching to a different BTK inhibitor, and typically it's from ibrutinib to acalabrutinib or zanubrutinib, or sometimes even stopping treatment and seeing how they do, because many patients may not need therapy for their CLL if they've been on treatment for quite a long period of time. And then again, there are other agents like venetoclax, for example, that we can switch to where some of these nuisance side effects don't really happen, like muscle aches, etc. And so in general, the threshold to switch treatment from one BTK inhibitor, if there is toxicity, to another is much lower now, given that we have a multitude of treatment options available. And otherwise, if someone's doing well on treatment, I tend to stick with that drug.
And I would add that these switches can go in all different directions. I mean, somebody was talking about being on ibrutinib and then they were switched to acala and had bruising and other problems. They could, if they didn't have those on ibrutinib, they could go back on ibrutinib. They could go on zanubrutinib and see there's the adverse event profiles are, while there's a lot of overlap, for each patient, they're different. And there's really encouraging data that patients who don't tolerate one can be switched to another, whether it's acala or zanu. And there's been some recent data on pirtobrutinib, which suggests that patients who don't tolerate, not just who progress, but who don't tolerate one of the BTK inhibitors can do well. So I think you can switch in different directions here. Do you have another question? And this gets us into a whole big area, is this whole area of combinations. So let me ask, just before we get to that, so I can segue into this, somebody asked about MRD, or measurable residual disease. We're trying to change the language to measurable because we think that's a better description than minimal residual disease. That's usually, when you use that term, you're talking about one cell in 10,000. Is that, and that's flow cytometry, but there's newer tests. Next genetic sequencing, clonoSEQ is the brand name of that. Talk to me about those tests, where you see those fitting in CLL, what their role is. And specifically, there is a question, is there any role for those in BTK inhibitors? You know, somebody's 4 years out, you know, everything is normal, they're doing great. Should we consider doing MRD testing on that person and seeing if they could stop, like we do with venetoclax? Lots of questions there for you on the MRD issue.
Great question. So MRD testing, the way, you know, it is done, like you mentioned, there are two major ways by which it can be done. One is through a peripheral blood or a bone marrow flow cytometry study, which, you know, is simple to be done. It's readily available, and you don't have to do a lot of preparation. Whereas for the clonoSEQ assay, which is a far more sensitive assay, you actually need to check the blood, but then there has to be a corresponding sort of blood or a bone marrow that should have been done before for them to make the comparison. So that there's just a little bit of a logistical issue with clonoSEQ. Having said that, clonoSEQ is far more sensitive. So, you know, it can detect one CLL cell in 1 million normal white blood cells. Whereas the flow cytometry study, typically the sensitivity is one CLL cell in about 10,000 normal white cells. So this is much more sensitive. The current guidelines really call it as undetectable MRD when it reaches in the 1 in 10,000 threshold. So this is a desirable endpoint, but clinical trials right now are trying to discern whether getting from here to the 1 in 10 to the power minus 6 or 1 in 1 million really is any different or not. So right now, we don't really have those data, and those trials are being done, and we are trying to understand, you know, does it matter whether we should go any deeper than 1 in 10,000? So currently, this is the threshold that I use, and this is what most trials have used. Having said that, what is important for us to understand is that currently we have information that tells us how patients are likely to do once you reach that threshold. Meaning patients who get to that threshold with fixed duration therapy, that is typically a venetoclax-containing regimen, those patients have a longer time to next therapy, have a longer what is called as progression-free survival, meaning freedom from progression of disease, which is a desirable endpoint. There are clinical trials that are ongoing that are testing whether extending the treatment duration, adding other drugs, or doing anything differently, if you haven't achieved this 1 in 10,000 threshold for undetectable MRD, will make any difference or not. And so those trials are still ongoing, and I don't think we have any definitive results as far as making any changes are concerned right now. Finally, to answer the question about someone who's been on ibrutinib for 4 years and is doing great and has no residual disease, you can certainly check an MRD, and if it is undetectable, you can have a discussion with your doctor about, you know, whether it would make any sense for you to stop and monitor the disease. That would be deviating from its current, you know, FDA-approved label. But I think so long as you have a discussion with your physician about this, so long as there is a plan to actively monitor for your disease, you know, to progression happening, I think it would be fair. I don't think it's a blanket sort of thing that everyone should do it. There are the risks involved. So we have seen patients developing withdrawal from BTK inhibitor therapy where they develop what is called as BTK flare. Some patients may have a faster disease progression. So I think it would be going against what the current FDA approval is. But again, if you can speak with your oncologist or your hematologist and there is a plan of how you tackle it, then I think it is reasonable to have that discussion.
I also think that some of our colleagues in the United Kingdom have looked at this 10 to the minus fourth, this 1 in 10,000 versus 10 to 1 in, or 10 to the minus 6, 1 in 1 million cells. And we're starting to see some early data, which makes sense that the deeper the remission, the longer the progression-free survival. So we may see the therapy evolve towards using the deeper MRD, but at this point, just getting MRD used is enough of a challenge to be done. So let me push on that and sort of use this to segue into a lot of questions about combinations. There's some interesting research going on about patients who've done well on BTK inhibitors. Should we be looking at adding a drug like venetoclax in to get those people to MRD and maybe not have to go on continuous therapy? And you talked about not deviating from that, but also when you were reviewing your slides, you talked about the fact that ongoing therapy may lead to development of resistance. So does it make sense? I'm doing great on ibrutinib, but I ain't there. You know, I still have residual disease. Should I add then and kick it while it's down and then be able to stop both drugs? Tell me what your thinking on that is and where the research is on that.
Yeah, those are great questions. So I think the way I think about this is if someone's been on ibrutinib for 3-4 years or acalabrutinib or any of a single agent BTK inhibitors for that length of period of time, then they are likely to be doing quite well. And if anything, you know, most patients don't have a lot of residual disease at that point. And so if you're really thinking about stopping treatment, checking the MRD status or looking at how much residual disease you have and stopping might be an option. I think it's really in the earlier course of treatments where someone has been on a BTK inhibitor like ibrutinib or acalabrutinib or anything for about a year or so, or maybe 2 years, where there is still residual lymph node enlargement or residual increase in the white count, is where the discussion about can we make this into quote unquote a fixed duration therapy. And that, you know, like you mentioned, Brian, there are many studies that have looked at an approach like this, where you can add venetoclax or you can add obinutuzumab, which is an anti-CD20 monoclonal antibody treatment, get to this undetectable MRD status, and then stop treatment. I don't personally do these things because the vast majority of our patients, either they are treated and have been beyond that time point, but I certainly think that it's a reasonable thing to talk to your oncologist and get it done. I think once you get 1 year worth of venetoclax at that time point, or 6 months of obinutuzumab, it is very likely that your disease will get into undetectable MRD status and you may be able to stop treatment. I just draw a little bit of caution in saying this is because we don't have large randomized studies that have done something like this. So we have no studies that have done where patients would get a BTK inhibitor for a year or two and then get these added. Yes, there are some studies, but they are not randomized studies. They're not comparative studies. So we don't have an approach where, you know, patients got ibrutinib upfront for a year and then got venetoclax for 6 months, compared to somebody who got ibrutinib and venetoclax right away, compared to a third arm potentially where patients would get ibrutinib as standard of care and then when the disease progresses, get venetoclax at the time of disease progression. So I can't be confident in telling which of these approaches is the correct approach. But I think it is reasonable to have these discussions with your oncologist. And I think the drugs are approved, and I think it makes total sense to try something like that.
And let me say a statement that might be radical, and I'd be very interested if you agree or disagree with this. And then we'll use this to segue into some of the doublet and triplet questions, because there's a ton about that. There's a ton of research. I mean, 2 of the oral sessions were, one was called doublets and one was called triplets. And those are the most important papers at ASH were just on these topics. Am I right in saying that at least at this time, there is no evidence to show that combining therapies together, whether it's 2 or 3 therapies, has led to improved overall survival in CLL, that taking the drugs sequentially one after another when you progress versus taking them all together at once, nobody has shown yet which is the better approach. Not meaning that one isn't better than the other. We just don't have that data. Is that fair to say that throwing everything at it has yet to be proven that it's better? It's better response rates, but whether you actually live longer is not yet proven. Is that a fair understanding?
That is absolutely true, Brian. And I think we have to be careful in putting everything together because I think, so there is a study called the CLL13 study that was led by our colleagues in the German CLL study group. And this study, there were previously untreated patients who were randomized into one of 4 treatment categories. Patients either got chemotherapy or a combination of venetoclax and rituximab, or a combination of venetoclax and obinutuzumab, which is Gazyva, or a combination of venetoclax, obinutuzumab, and ibrutinib, the so-called triplet regimen. And what was interesting amongst many things that were shown by Dr. Eichhorst at the recent meetings was that there was no difference between patients who got venetoclax, obinutuzumab, and the patients who got the triplet regimen with respect to undetectable MRD rates or the length of time or the progression-free survival. Of course, this is early on, and so we don't really understand the impact of the triplet regimen so far. There are many trials that have completed accrual. We are eagerly waiting to see the results of the ECOG study, of the Alliance study, the CLL17 study, for example. And so all of these are still being in the context of a clinical trial. And so we don't really know the results. And so, yes, it is important to study these questions in the clinical trial world, but I don't think we are quite ready yet to translate these things into routine practice.
So let me follow up on that. Zanubrutinib was just approved in the last couple of weeks. There are ongoing trials of combinations there. Is there anything there that's particularly exciting to you as a dancing partner for zanubrutinib? And if you could talk us through a little bit about how you make those decisions. Let's say you've got a relapsed refractory patient at this point, how you make a decision about single drugs, double drugs. Let's add, because people say, let's say this is a higher risk patient. They have 17P or TP53 or complex karyotype. So how do you make those decisions for those patients? And if you could focus a little bit on zanubrutinib, because we've got a lot of data with Acala and ibrutinib, but the zanubrutinib data is just starting to emerge.
Yeah. So I think, if a patient needs treatment and has previously received therapy, so in a relapse refractory setting, I think the first question, of course, is, okay, what was the type of treatment that you received previously? So if a patient has received, let's say, bendamustine and rituximab or any other chemotherapy 5 years ago, and now they have progression of disease, and we are having a discussion about what kind of treatment option would make sense in a situation like this, I think there are 2 major classes of drugs that we talk about in the clinic. One is BTK inhibitors with either ibrutinib, zanubrutinib, or acalabrutinib as treatment options, and another sort of treatment option is venetoclax-based treatment. And so, in general, given some of the recent data, because that have shown that acalabrutinib and zanubrutinib are likely better tolerated compared to ibrutinib, if that is the treatment option that we choose, then typically it's one of those 2 drugs given as a single agent on a continuous fashion until disease progression occurs. On the flip side, there is a study called the Murano study that showed that fixed duration therapy with venetoclax and rituximab for 2 years works very well as well in this relapsed setting. And so in a patient that has never received any of these new drugs and is now first going to get one of these new drugs, it's typically either zanubrutinib or acalabrutinib given as a single agent continuously, or a fixed duration therapy of venetoclax and rituximab for 2 years. So that's one sort of patient scenario. Now, if there is evidence of high-risk disease, such as deletion 17P or a TP53 mutation, typically a fixed duration therapy with venetoclax-based treatment is not associated with a long progression-free survival. And so there, we typically try to go to a continuous BTK inhibitor-based treatment, and that really means either zanubrutinib or acalabrutinib. Now, it's different, if patients who have received ibrutinib or acalabrutinib or zanubrutinib and they have disease progression. So typically there, we would talk about venetoclax-based treatments, or with one of the newer agents such as pirtobrutinib or nemtabrutinib, or obviously participation in a clinical trial becomes very important over here. On the other side, if you've never received a BTK inhibitor and have directly gone from chemotherapy to venetoclax, or have never received chemo and have received venetoclax as their first-line therapy, and if there is disease progression in that group of patients, again, it depends on how long has it been from your last venetoclax-based treatment. If it's been more than a year or two, I think retreatment with venetoclax works in that group of patients. But if it does not, then going to one of the BTK inhibitors, such as zanubrutinib or acalabrutinib, would work equally well in that approach. And then I think, like we mentioned, patients with double refractory disease, quote unquote, double refractory, meaning refractory to both a BTK inhibitor and venetoclax, is a growing population of patients where novel clinical trials, pirtobrutinib, nemtabrutinib, these BTK degraders, CAR T therapy, et cetera, are all important treatment options.
Yeah, I'm ready to pull out the hair that I have here because we don't have time to get to all these really great questions. There were a number of questions on COVID that I wanted to talk about. And someone asked if, and apparently, and I haven't seen this, the CDC recommended a booster shot today of the bivalent vaccine for the immunocompromised. Would the CLL population be part of that? And the answer is absolutely yes. Anyone, regardless of your treatment status, treatment naive, watch and wait, in a deep remission, every CLL patient is immunocompromised to a greater or lesser extent. And if the CDC is recommending a booster after 6 months of a bivalent, and that kind of makes sense to me for the immunocompromised, we should be first in line to get that. How does COVID play in? We know that a number of these drugs, especially the monoclonal antibodies, suppress your ability to respond to the vaccines. But we're also seeing some encouraging data with COVID. When I talk to the CLL experts, and I wonder if you'd weigh in on this, they're not seeing the horrible morbidity and mortality that we saw early on with COVID in their CLL patients. Not that they don't get it, not that it's not that there's occasional tragedy. So can you talk a little bit about the state of the art now with COVID, and what are you telling your patients and how that weighs in terms of these multiple therapies? Because the more therapies, the more immunosuppression.
Yeah, it's a challenging discussion, as you can imagine. And you're right, Brian, I think things have gotten much better. So I can say that 2022 was a much better year for the vast majority of us as physicians caring for CLL patients compared to 2020 and 2021. I think, the availability of vaccines made a huge difference. And so I encourage everyone to get all the CDC recommended vaccines, including the more recent bivalent. I'm not aware of the thing that came out today, but obviously, as Brian mentioned, if that is really a recommendation from CDC, we certainly support that. And everyone, regardless of your treatment status for CLL, is considered to be immunocompromised. And so you should be able to get the vaccine. I think from late 2021, early 2022, what we've seen is the use of Evusheld that really went up, and a number of patients actually got 2 doses until it was taken off the market last month, which I think certainly helped. The availability of Paxlovid also has made a difference in our ability to treat COVID infection. And now, obviously with the availability of convalescent plasma, because none of the monoclonal antibodies unfortunately work for COVID-19, that has also played an important role in our ability to treat patients that get COVID infection. And so I think IV remdesivir is still used not infrequently, although maybe its efficacy is not as good as some of the other things that we do. So in general, I think, given the number of vaccinations that the vast majority of our patients have received, the fact that Evusheld, is still around, and maybe it's not the perfect treatment, but some amount of Evusheld is still better than nothing. At least that's my personal belief, because there is cross-reactivity of these antibodies that can maybe not completely neutralize the new variants, but it will still help some. And I think the availability of Paxlovid and convalescent plasma, remdesivir. So we've come a long way in our fight against COVID. I think in general, We do think about it. It is at the back of our minds as we counsel our patients. But increasingly, I think we think that the outcomes from COVID infection in our immunocompromised patients has improved. And that really has been borne, in the data that we have seen at ASH and even in the years past, that our patients are doing better with COVID infection.
So let me answer a couple little questions here that people asked. Are there new BTK inhibitors in development? The answer is yes, not just these, but there's new ones coming. Are there new BCL2 inhibitors coming? The answer is yes. Lysaptoclax is probably the one that's furthest along, but there are new ones that are coming in the pipeline there. The role of IVIG, I think that for patients who've had recurrent respiratory infections and have low levels of IVIG, the data are strong, that it's helpful. But if you're not fitting into that category, it's a discussion to have with your hematologist. It is used sometimes in a broader sense of that. Let me finish before we get to final thoughts on an important question that you must deal with, and I'm seeing more and more of, the young CLL patient. So somebody wrote in, and I'm in my 30s. Dr. Parikh, how you got somebody who comes in their 30s, and I've even seen people in their 20s now diagnosed with CLL. This is a whole different discussion you have with that patient. So what are you thinking about? How are things are different? And where is the research going for these younger patients?
Yeah, no, that's always a challenging discussion, Brian. I mean, I think, the median age or the average age at which CLL is diagnosed is in the 70s. And so I think, I tell my patients that, my job is to get you to what the average life expectancy is of a normal or a person living, without CLL, and that's in the mid 80s to 90s. And so I can confidently look in the patient's eyes when they're in their 70s and tell them that, look, we have the tools to get you there, but, can't really do that in someone who's in their 20s or 30s because the drugs that we have now have not been around for that long. Increasingly, I think trying to minimize toxicity and maximize efficacy, which we would do for anybody, but I think in a young patient population that is particularly true. So I find myself going towards fixed duration therapy using venetoclax and obinutuzumab as my first line therapy, so I can get a very good response. I do not have to have the patient continue with treatment for the long term to avoid some of the side effects of chemotherapy and the side effects of continuous BTK inhibitor-based treatment. But it's not an easy discussion because the outcomes of these patients it's hard to predict how things will go. However, having said that, I think there are plenty of data that suggests that we have many effective treatments and many treatments that will work once the frontline or second line treatment stop working. So I'm certainly encouraged by all of that, but I know it's hard to have that discussion with people in their 20s and 30s.
Samir, there's so much more we didn't get to CAR T, we didn't get to, people asked about complex karyotype and trisomy 12 and 6q delete. There's so many great questions here that we didn't get to about adding in antibodies, and but we'll try to keep things on time. So I'll give you a minute or two to kind of summarize if there's any takeaway messages from ASH, from the ongoing research, anything that you want to highlight that's going on at Mayo that we should know about as patients.
Yeah, no, again, thank you, Brian, for the opportunity. It's always a learning experience for me as well as I listen into these questions, because like I said, I think it's our patients who really drive what we do as researchers and try to make sure that, what we do is reflective of helping our patients. I think we've come a long way. I think in the last decade, the treatment options for our patients have significantly changed. A lot of very good treatment options, but a lot of work needs to be done. I think the exact sequencing of treatments, the restoration of the immune system, tackling relapses after some of the frontline therapies that work the best, I think those continue to remain challenges. And then, like you mentioned, Brian, I think reaching every single CLL patient, no matter, what the color of their skin is. And I think that is very, very important. And I think over the next years, hopefully we'll be able to get all of these things done, and which will obviously be good for all our patients.
Well, thank you, Samir. I do want to point out, let's wait until we get confirmation from the CDC about this booster shot. We were just kind of researching this during the meeting and can't find that, but stay tuned to the website and we'll bring you up to date on that. And a lot of the questions that were asked, what you can find on the website. People had some great ideas about medications and a spreadsheet and stuff like that. So, stay tuned and we'll try to do that. I always learn from you, Samir. I'm very grateful to our generous donors and the grant support from AstraZeneca, Beijing, and Lilly for making this event possible. And I want to thank everyone for joining us today. A big thanks to my friend, Dr. Parikh, who serves on our medical ad board and is just a great guy in terms of helping patients. Please complete our post-event survey. Your feedback is critical to us. We listen and we make changes based on that. We didn't get to a lot of your questions, I admit it, but Ask the Expert is there for you. We have something exciting coming up, Ask Me Anything, with Dr. Brian Hill, who's at Cleveland Clinic, and Jeff Folliter, who a lot of you will know from his very busy on Facebook as a patient and a patient advocate. And I always remind you that we are a nonprofit. CLL Society is invested in your long life. Please invest in the long life of CLL Society by supporting our work. Thank you all for attending, and I hope to see you on March 22nd for Ask Me Anything. And I look forward to another webinar in a month from now, where we'll be looking at the early processes in CLL before you need treatment. What do you do when you're first diagnosed? So stay tuned for that on the website. Thanks to everyone and have a great afternoon or evening.
Thank you.